And without further ado, let's get this going here. So tonight's call, we're going to be talking about men infertility. And before I jump ahead and introduce John, we're just going to talk a little bit about what we're going to be covering tonight on tonight's webinar. Many of you who are new might not know that we do actually hold a number of these webinars. This is a new series for us for 2012, and they've been going really well. And we focus a lot on topics and discussion that usually focus around women. So we, knowing that it's November and we're focusing on men's health, we took the opportunity to talk about male fertility. So we're going to be talking about the basics of male fertility, lifestyle choices that can boost male fertility, the role of antioxidants and amino acids that have been improving sperm quality, advanced testing and treatment for male fertility, and a few other topics. So lots of great information tonight. And without further ado, let's introduce Dr. John McNaught. So for anybody who doesn't know, Dr. John McNaught is the founder and medical director at Fertility Ontario, a provincial leader in fertility care. In 2008, Dr. John McNaught closed a busy surgical and obstetrical practice to focus primarily on the diagnosis and treatment of infertility. Since that time, John has gained a reputation for working tirelessly on behalf of his patients. In addition to working almost every day at Fertility Ontario, John spends his spare time updating the Fertility Ontario website and answering emails from his patients. Dr. McNaught is also an advocate for effective fertility therapy and has been quoted in both the provincial and national media in support of funding for fertility treatments. In addition to advanced techniques such as in vitro fertilization, Dr. McNaught has gained a reputation as an expert in natural fertility methods. Over the last couple of years in particular, he has increasingly used vitamin antioxidant therapy to help several couples realize the dream of building a family. So without further ado, thanks, John, for joining us tonight.
Thanks a lot, Melissa. I'm very pleased to be here. I'm amazed at how many people turn out on a Monday night because this is about male fertility, and there's professional football on TV, so we're competing with them. I just have to get the sort of legalese out of the way. This is not specific medical advice. It doesn't apply to you as a particular patient. The medical information offered is general and doesn't constitute specific medical advice. Was that legalish sounding enough?
I think so. It was pretty good.
I think so. Yeah. Tonight we've got a big topic to cover. You know, men and fertility is something that we often overlook because a lot of the focus of modern fertility therapy is on female fertility. But when a baby is made, half of the information comes from the male chromosomes. And increasingly we're putting more focus on the sperm and the genetic contribution from the male aspect to determine where the difficulties in achieving pregnancy are coming from. As you know, there's still a tremendous number of cases that are considered idiopathic and or unexplained in terms of why people are unable to achieve pregnancy. And in a lot of cases, that's a male factor that just hasn't been identified yet. We'll delve into that a little bit today. Okay, so Mel already took us through what we're going to be talking about today. Everything that we're going to be talking about is purposely very basic. We're not going to be getting into specific or rare diagnoses because I think that eats up a lot of available time and might not apply to a large number of people. So what we're going to do is keep things as basic as possible, and hopefully that will generate some individual questions from the many people that are in attendance. So, you know, we're broken up into, I think, 4 different segments. And at the end of each, please don't hesitate to stop and ask some questions, because that's really where this becomes a dynamic process and where we all learn from one another. So the basics involves a concept that I really, oh my God, I spelled understand wrong. I really need people to understand, and that is this concept of how long it takes a mature sperm cell that is capable of fertilizing to actually be made. And this is something that I talk to my patients about and I refer to as the assembly line. And for human sperm, the assembly line is close to 3 months in length. So that if you want to make a change in either the quality or quantity of human sperm, you need to have at least 3 months in order to see full result. As an example, when we put people on things like vitamin therapy, we see a qualitative result in a few weeks, but we don't see the full result until about 3 months down the line. The basic biology of sperm is that, as most people know, they're produced in the testicles in these thread-like tubes called seminiferous tubules. And they sort of migrate from the outside in, and as they move towards the center of the tubules, they become more mature over time. And again, that full maturation takes about 3 months. What you're seeing here in the middle is a long tube called a vas deferens that's cut in cross section, and in the middle here, what you're seeing are millions of individual sperm cells that are being evaluated under a microscope in the middle of the vas deferens. Sperm, just like the human egg, are very closely regulated by hormones that originate in the hypothalamic area of our brain. And hormones that you might be familiar with, such as follicle-stimulating hormone and luteinizing hormone, regulate sperm production in much the same way that they regulate the human egg production or maturation. So follicle-stimulating hormone, or FSH, stimulates the cells in the seminiferous tubules to produce sperm. LH, or luteinizing hormone, stimulates the Leydig cells to produce testosterone. And testosterone is very important for sperm function. A lot of men will have testing done that suggests that they're deficient in testosterone. And an error that I've seen made by both patients and physicians is that when they think that they're low in testosterone, they will choose to supplement with a pharmaceutical form of testosterone. With respect to male fertility, that tends to have a disastrous outcome, because when you supply testosterone into the body, the organ system in the body that makes testosterone says, my job is done. And that organ happens to be the testicle. So in areas where testosterone is being supplemented, you'll find that sperm production by the testicle can drop rather quickly. So regardless of what your testosterone testing might show, there is never an indication to supplement with testosterone in men who are trying to get their partners pregnant. So when we have mature sperm, it needs to find a way outside of the body, and that is obviously ejaculation. We have other ways of extracting it from the body, but the old-fashioned way tends to work best. Once these sperm are mature and they're released into the middle of the tubule, they're not actually fully mature until they travel through the epididymis, which in turn leads into a large duct called the vas deferens. And you can see that these here are the vas deferens, very long in reference to the other anatomy associated with male production. And so there's quite a large surface area along which the sperm travel. The actual semen isn't produced until the vas deferens meets up with an area called the seminiferous ducts. And at that point, the sperm is added into the semen such that only about 5% of the total volume of ejaculated semen is actually made up of sperm cells. So we have questions a lot about from patients about acts of intercourse or acts of insemination, and they say, I don't know if I produced enough, or there was a lot more on that particular time. Volume is not really that important because semen is just a carrier for sperm. It's a delivery method. And how much you are able to see visually doesn't correlate to how much sperm is actually in there. So that's the basics in terms of male biology, and quite honestly, I think for our discussion tonight, that's all that is required to know. Things do get a lot more complicated the more you delve into male fertility therapy, but I think for the purpose of our discussion, it's best to keep things very, very basic. At the end of the day, you need moving, swimming sperm in order to fertilize an egg, and that's what it's all about. Are there any questions about our quick little biology lesson there?
So far, John, no questions in the question panel. But again, if there's any lingering questions that you're thinking about, feel free to type them anytime, and we'll kind of address them at each stage here.
Oh yeah, and I'm always happy to, go back to things at the end. I find that the grade 9 biology stuff is not what people want to talk about. Most people who have been dealing with this are pretty well versed in that already. I sort of obligatorily had to do those slides because every once in a while I come across somebody who says, "Oh, I didn't know that," particularly in relation to how long sperm take to become fully mature. And I think as you go through this process, just those key concepts will make more sense as we go along.
Actually, John, we just had a question come in. Um, and this is actually a great question. We have a question here from James asking, how does heat affect sperm production, such as hot showers or for somebody who works out a lot?
Sperm are very, um, they can be, the process is known as denatured. So the protein components of sperm at high heat essentially will cease to function. They are kept outside the body for a reason. So you know that your internal core temperature runs about 37 degrees or so, which is quite warm. The sperm, if they're exposed to that temperature on a chronic basis, will will cease to function, and similarly the testicles will cease to function because they're quite heat sensitive as well. The classic example is somebody who doesn't have normal descent of the testicles into the scrotum as part of a developmental abnormality. And if the testicles stay inside the abdomen, which is 37 degrees, for an extended period of time, even when they eventually are dropped into the scrotum, there is usually a severe detriment to sperm production and function. And some guys will have complete absence of moving sperm on that basis. That's the most severe example. Other more temporary effects are seen with things like hot tubs, vigorous exercise, although exercise is generally good for you. Um, and we see it as well in a condition like a varicocele, where if there's some swelling of the veins that surround the testicle, they can generate a lot of ambient heat as well. And that's one of the ways that varicoceles impacts male fertility.
Wonderful. That's so far the only question that we have right now. James, you can let me know if that answered your question. And I guess one lingering question I had, John, was like how, exercise is really important. That's probably one of the lifestyle choices. I'm wondering, when does, like what's kind of the line when it comes to exercises? I know people in my life that exercise quite rigorously for an hour a day. Like, would that be too much?
Not really, because the chronic exposures in life are always going to have a more significant impact than things that we do for 45 to 60 minutes throughout the day. So small temporary insults aren't going to have a lasting impact. Um, Even when you are working out very vigorously, you have to remember that the organs in question are still separated from the rest of the body. So they're not likely to get to high temperatures no matter what you do. Some of the issues with, like the classic example is the hot tub. You're directly immersing those organs into a relatively hot temperature. That's been shown to have a temporary effect on um, the sperm that are ejaculated shortly thereafter, but it's not like a hot tub would ever be considered a contraceptive, right? There's there's exceptions to every rule. If you look at, we're going to talk about this in lifestyle, things like cigarette smoking, marijuana smoking, binge drinking, those have a much more significant impact than having the occasional hot tub or working out, which is probably something that is beneficial on the long run.
Awesome. And I have another question in here. We have a question from Gord. He's wondering, how does he improve the viscosity of his sperm? He's saying that he has one testicle higher than the other. Is that the issue for having? Is that my issue for having a child with my wife? So I'm thinking that's kind of reworded to say, is that kind of why there's possibly an issue?
Probably not. It depends on the degree of anatomic abnormality that exists. One of the things that I talk about later on is that for guys who think that there may be some sort of anatomic disruption, a consultation with the urologist is a great thing to do. With respect to sperm viscosity, volume and viscosity are not huge players in terms of fertilization. Again, that is more of a semen parameter rather than a sperm parameter, and you just need to get sperm in the general vicinity, and if they are competent, they will swim. I've seen a lot of people use, you know, sort of natural health choices like fish oil and things like that in trying to improve either the volume or viscosity of semen, and that's not something that is really shown to be particularly beneficial. There are some fertility techniques that wash the sperm and get rid of the semen, and they seem to have some benefit. It might be on that basis, but those factors in terms of that have more to do with semen than they do with sperm aren't going to be the difference maker in terms of achieving pregnancy.
Awesome. And we're having another question trickle in here. This question is from Steve. He's saying, would skin conditions on the penis and testicles affect sperm production or motility, such as moderate to severe, and I'm not going to say this word correctly, but PSORIOSIS?
Psoriasis.
Thank you.
Yeah. The answer, Steve, is I don't know. When I was a resident, I did some research with respect to semen parameters, sperm parameters in men who had chronic diseases. These are guys who had been diagnosed with a type of cancer and were awaiting sperm banking. And we saw that even before they went through chemotherapy or radiation, on the basis of having a chronic disease, their bulk sperm parameters were lower than average. Now, with a skin condition like psoriasis, I'm not familiar with an association there, but it is an inflammatory condition. In particular, if it's very irksome and it causes a lot of irritation that may generate a local heat reaction, So, like, the best thing to do in that scenario is always to get a proper semen analysis, see what you're dealing with, and then you can think about factors that could alleviate it.
Awesome. Awesome. Thanks for helping me out with that word, John.
No problem.
And that's all the questions that we have for right now.
Cool. So we're going to go on to the next section, which is something that generates a lot of questions for people because they're always looking for ways to improve natural fertility. And I think, one of the things that I touch on at the end is it's best to try and deal with a holistic approach to male fertility sooner rather than later, because as you try month after month, the prospects for natural fertility seem to appear to be less than what they actually are. And a lot of people will seek medical fertility therapy just out of emotional fatigue from trying at home, where, with each negative pregnancy test, there's a lot of pressure and anxiety that builds. And it's sometimes tough to go back to a natural fertility approach when you're already frustrated with either intercourse or your intimate relationship at home. So this is something that is really best dealt with in an upfront way. The first and probably the most important is the association between all types of fertility problems and obesity. Um, Obesity is associated with a lower gonadotropin level, lower testosterone level, and a lower available testosterone, depending on how significant the increase in body weight is. There's also a decrease in what's called SHBG, or sex hormone binding globulin, that contributes to low serum total testosterone concentrations. So men who have a significantly elevated BMI can have a process that develops that is analogous to polycystic ovarian syndrome in women, where their increase in body weight shifts their metabolism in favor of the wrong hormone background in terms of proper either egg development or sperm development. And it actually improves with weight loss. There are lots of non-fertility motivators in terms of achieving a healthy body weight, but we certainly see that men who are significantly obese will often have fairly severe changes in their sperm concentration. Cigarette smoking is another thing that we always ask about. It's obvious that everyone who is dealing with a tobacco addiction really needs to consider quitting. There's not a perfect correlation between smoking and infertility, because everybody is aware of that person who smokes a pack a day and has 4 kids, right? But the studies that have looked at sperm counts both in infertile and normally fertile men always show a decrease in sperm count in comparison to non-smokers. So if your partner or yourself, if you need some extra motivation in terms of kicking the habit, increased fertility is just another health benefit of not smoking. And finally, the thing that you have to consider is that you're planning on adding a child to your household. And that's obviously motivation to become smoke-free, because you don't want a child in a cigarette-filled household. Sorry if that was a little preachy. Along that line, marijuana is a lot more detrimental in comparison to tobacco, because it actually, tobacco is more of a vasoconstrictor, like a blood vessel moderator. Cannabis actually suppresses the secretion of testosterone, often causes decreased libido, and it's famous for causing drops in both sperm count and motility. These can often be very dramatic, and it can be prolonged. So men who are trying to start a family really should not be smoking marijuana, even occasionally, because it's very fat soluble and it lasts in the body for a long time. The question that comes up quite frequently is about alcohol use, and the consensus right now is that alcohol in moderation is fine. It's probably good for the heart in small amounts. It doesn't seem to have any detrimental effect on fertility, also in small amounts. But in large consumption, particularly when the pattern is binge drinking, that is an area where we can see a certain amount of hypothalamic suppression, and we actually see decreased circulating hormone in patients who are very heavy drinkers. So you need to have an honest conversation with yourself about what your pattern of alcohol use is, and if there's room to improve, there's often a benefit in terms of sperm production. We're going to spend a lot of time talking about nutrition because I think a lot of us would agree that we don't really eat well enough. We've talked about the links to obesity, but even in relatively lean men, an unhealthy diet can lead to negative effects with respect to male fertility. So whether you are not eating well enough or not getting the elements that you need in your diet, somehow you have to find a way to get these components into your system. The classic one, which I'm sure a lot of you have read about, is zinc. It is very active in terms of cellular metabolism. It plays a role in DNA synthesis, which is very important in sperm production. And it's something that you really require a constant supply of because the body can't store it. So if you're not getting it into your system on a regular basis, it's not something that you can stockpile. And the classic food that contains zinc are fresh oysters, which at one point were known as an aphrodisiac. So there may be a dual role for something like this in terms of boosting male fertility. If you don't like oysters, there are lots of very potent commercially available supplements that you can consider. B6 and B12 are also important in the production of both red blood cells and DNA, and so they're very important in terms of maintaining sperm production. Vitamin C and vitamin E are good natural antioxidants, and they have been shown to improve sperm quality. It's not really hard to find a natural source of vitamin C and vitamin E. Supplementation is available, but realistically, if you're eating anything close to a balanced diet, you should be able to get these into your system. Arginine is an amino acid that provides blood flow to both male and female genitals. And because the testicles are very sensitive to blood flow, having something that improves the blood supply to that organ is important. Finally, lycopene is a natural antioxidant that has been shown to improve sperm motility, and it works very well with my favorite antioxidant, which is coenzyme Q10. CoQ10 is the most important antioxidant that needs to be supplemented, and it is the one that has the most scientific evidence behind it. It's been shown to significantly boost both sperm motility and sperm function, and men who take antioxidant therapy with coenzyme Q10 are clinically and statistically more likely to get their partners pregnant. And this is my current favorite source of coenzyme Q10, Vital Q, which is the activated form of CoQ10 as ubiquinol. This is a tremendous supplement, and it's something that if we are treating people in terms of male fertility, a good source of CoQ10 is a must. And then finally, with regards to lifestyle, I talk a lot to people about their sexual practices. I find that both men and women um, will make the mistake of trying to pinpoint the moment at which the egg is ovulated. And men will often store up sperm because they think they'll have higher numbers at the time of ovulation. This actually is detrimental because the longer that sperm are stored, the more likely they are to degrade and break down, and they don't actually swim that well. So in our clinic, we have what's called the 5-day rule. And that means that no more than 5 days are to go by without intercourse or ejaculation. Even if you view it as a time of the month when your partner is not fertile, you should either be having intercourse or ejaculation every 5 days. Sperm swim better, and conversely, if you don't focus around the precise timing of ovulation, you'll find that intercourse is less rigid, a little bit more spontaneous, and hopefully will decrease some of the anxiety that men feel around intercourse. If you're looking for a more in-depth discussion around my approach to natural fertility, there's an ebook on our website called Baby Steps. It's only about 14 pages, and it goes into some of the thought behind the coaching that we do for men and women who are trying to become pregnant naturally.
And John, I've got a question here. I actually have a
Yep.
few questions. I have a question here from Steve. He's asking, would you also suggest L-carnitine? I'm hoping I'm saying that one right.
Yeah, L-carnitine. I like L-carnitine quite a bit. For a long time, it was one of the main amino acids that I used. Um, I've moved away from it a little bit because there's a little bit of controversy about whether or not it's truly effective or not. If it's like on its own, I no longer prescribe it solely on its own. But if it's included in a fairly robust vitamin supplement, I think it still has benefit. I think if you're looking to L-carnitine as your sole amino acid source, it probably can't do the job on its own. But if it's used in concert with something like coenzyme Q10, I think it still has value.
Awesome. Awesome. And I have a question here from Gord. Gord is the same person that asked a question previously. He's got a follow up question. He's saying that he has bladder reflux and has high I'm creatine. I'm hoping I say that right. These words are killing me here.
Yeah.
Creatine levels. Would that be bad for his sperm?
The bladder reflux can be an issue. Sometimes in that setting, we'll see retrograde ejaculation as well. I don't know if that's what he's talking about. The problem with exposure of sperm cells to urine is that it changes the pH, which changes their ability to swim. So oftentimes what we'll have to do is, for guys who have retrograde ejaculation, is we have to alkalinize the the urine, so that it's more favorable for sperm function. And then after an ejaculation like that has occurred, it's retrieved out of the bladder. It is very, very complicated. Um, I think in that setting, if you've got a urologic issue like bladder reflux and some element of renal dysfunction as well, realistically, you need to be seeing a good urologist who's trained in male fertility. If you email me after this webinar, I can suggest somebody locally to us who's fantastic with male fertility from a urology standpoint, or I might be able to identify someone who's closer to you.
Awesome. Um, I have another question in here for that kind of talks about our last slide there, um, which talks about, yeah, sexual practices between men and women. We have a question here from James. He's saying for intercourse, should your partner be on their back with their hips elevated with a pillow for the best chance of conception? And if so, how long would your partner stay in that position after ejaculation?
Yeah, again, there's, that's something that has actually been looked at, and it's found its way into sort of the realm of the old wives' tale. It doesn't help. There are rhythmic contractions of the uterus that literally suck up sperm as soon as ejaculation occurs. So they're on their way within moments of ejaculation. The the often people will notice that there is semen that kind of drips out after an active intercourse, and people think that if it's not kept within the vagina, then they won't have the opportunity to fertilize, right? What they don't realize is that by the time semen is moving its way out back out of the vagina, the sperm is already well on its way, or at least any sperm that is swimming competently. So in terms of putting yourself in that position and trying to let gravity give you an assist, there's no basis for that at all. You should choose the sexual position that's most comfortable for you and your partner and try to be as spontaneous and intimate as possible.
Awesome. Great answer. And that's all the questions we've got right now, John.
I do want to talk about diagnostic testing a little bit because there's people generally are not aware of what is available in terms of sperm testing. What most people are familiar with is visiting with a doctor, and of course, we will go over with you. We ask you about lifestyle issues that come up. We ask you about how you developed as a child, and sometimes I can get some clues out about areas that I should be looking. On all patients, I order what's called a basic semen analysis. And the reason I start here is because this test is usually covered by the government. Um, the results surprisingly take a while to come back. It's a week to 2 weeks before we see the results, which is unusual for what is a live test. I consider this very basic, and really I use it only as a screening test. Um, your parameters need to be pretty normal for me to be satisfied with the information that we get from this. The World Health Organization criteria for a basic semen analysis were recently revised. They're a little bit more forgiving. The sperm concentration is now considered normal at 15 million, with a total number of sperm normal at 39 million. The morphology by what are called strict criteria are considered normal if there's more than 4% that are essentially perfect from a size and shape standpoint. And then the other issue that we get into is the issue of motility. And this is really the one that we see the most variability with in terms of how outside labs report it. The reason for that is that, and the guys in our IVF lab will tell you this, if a sperm is not swimming in a straight line, it is not going to fertilize an egg. And so progressive motility, the ones that are moving in a normal vector, are the ones that are actually going to fertilize an egg with good probability in a natural setting. So, like as an example, I recently had a guy who his overall motility was 40%, but his progressive motility was only 6%. And, not uncommonly, your family doctor is going to look at that and say, oh, okay, well, about 40% of your sperm are swimming, that's a good thing. And I look at that, or my lab looks at that and says, whoa, this guy's only got 6% progressive motility. And then what we do with that is we go on to an advanced semen analysis. And this is really, if we're ever considering actually putting you through fertility therapy, this is an absolute must, because our fertility laboratory can't tell you what your options are for male fertility until we actually look at the sperm using an advanced semen analysis. So you get your count, you get your concentration, and you get your motility all your basic info. Plus, we also screen for what are called anti-sperm antibodies. We screen for immune cells. We evaluate very strict size and shape of the sperm. They're put through what's called a density gradient analysis, which is the same way that we prep our sperm for insemination. So if we're considering insemination, we make sure that we have appropriate numbers by that test. And then finally, we go through a swim test as well, which is where this test sometimes gets its name. We refer to it as the Monash, after Monash University in Australia. And by the time we see the results of the advanced semen analysis, we can say with some confidence to people that this is sperm that's suitable for intercourse or insemination, this is sperm that needs in vitro fertilization, or this is sperm that needs ICSI. And you cannot tell that information from a routine semen analysis.
And John, I have a few questions popping in here.
Yeah, I figured.
Because this is a great topic. We've got a question here wondering how much an advanced semen analysis costs.
At our laboratory, it costs $250. And, it's unfortunate that it's not covered by the Ministry of Health. There's a lot of laboratory work that goes into it. It is something that, unfortunately, it's mandatory if you go through insemination or in vitro fertilization. But when you look at the information that you get from it, it's generally money well spent.
Okay, awesome. And I have a few other questions here. We've got James, and he's saying he has a sperm test on Friday. He was told to refrain from ejaculation for 3 days after this evening, actually. So he's wondering, how should I prepare for good, accurate test results, i.e., diet, avoid stress, like that type of information?
You know what? There's a huge variability from one sample to another, so don't worry about it. You know what? If you want to get an accurate test, do two. That's how you improve the accuracy of a basic semen analysis. If there is a moderate amount of motility on a basic semen analysis, that's a pretty good indicator. If there's something really wrong, like if there's a very low number of sperm or a very low amount of motility, I would just move on to an advanced semen analysis after that point. But don't stress out about the basic semen analysis. There's nothing that you can do that's going to improve the results. The guidelines for abstinence are there just to make sure that you haven't had an ejaculation immediately prior to, but it's not like your sperm count drops to 0. So the information isn't going to change a whole lot no matter what you do.
Awesome. Awesome. I have a question here from Matt. He's wondering, what effect does motility and quality of sperm have when doing IVF?
Um, we'll get into this a little bit, but motility in IVF is relatively important because they still need to swim. If we ever thought, even though they're placed very close to the egg, they still need to swim in order to penetrate the egg. If we thought there was an issue with motility, the preferred method of fertilization is something called intracytoplasmic sperm injection. So, if there's ever an issue that way, ICSI is sort of a safeguard against going all the way through an IVF process and not actually getting any fertilization. What was the other one? Was the other one morphology?
Motility and quality.
Well, quality is a difficult thing to assess, but the one that comes up very often is the strict morphology. And there are people who say that if there's a low amount of strict morphology, that you should be doing ICSI as opposed to strict IVF. That's something that is debated very hotly amongst our scientific community. But I trust my IVF laboratory, and if they ever suggest to me that a gentleman should have sperm injection as opposed to IVF, I usually abide by their decision because they're the people who look at embryos all day, and they do semen analyses all day, and they're very, very experienced. If someone is offering you good advice, I usually advise people to listen.
Wonderful. Wonderful. And I have another question here. Christine, I didn't forget about you. um, this is, I think this kind of goes back a little bit to the slide about couples here. But Christine has a question with, she's saying, seeing as to how it's prostate month, is it beneficial for you and your partner to practice prostate massage to increase blood flow and oxygen to that area and hopefully encourage sperm production?
Not that I'm aware of. It's something that there are conditions in which there are blockages within the ducts and the tubules that make up the male reproductive system. In that setting, massage can sometimes help to ease the blockages. But in the setting of all you're doing there is maybe helping the release of preformed sperm. You can't actually change production because that occurs right at the level of the testicle. If you're trying to get an improvement in the release of formed sperm, massage in and around the pelvic organ, not necessarily the prostate per se, may be beneficial, but it isn't going to change the sperm production because that happens well away from the prostate.
Got it. Thanks, John. And that's all the questions we have for right now.
Okay. The last sort of advanced test that I want to talk about is something called DNA fragmentation index. It's something that in the last 6 months I've been getting a lot of questions about. And I think the reason that it generates a lot of questions is that if you talk to 4 different fertility specialists, you'll get 4 different answers with respect to DNA fragmentation index. So this is a laboratory evaluation of sperm that is expressed as a percentage, and it evaluates breakages in the DNA that make up sperm that sort of assesses the fragility of the chromosomes that make up sperm. If we see a DNA fragmentation index or a DFI that exceeds 30%, there's usually a guarded prognosis for natural fertilization either through IUI or intercourse. The reason that a lot of specialists are down on this particular test is because those specialists are already performing very advanced procedures like intracytoplasmic sperm injection. And in the setting of ICSI, you can still get pregnancies with an elevated DNA fragmentation index. And so there are people who say that this test doesn't have any usefulness. It's not a test that you would apply to a large number of male patients, but in select situations it has a lot of utility. For people who have failed multiple courses of intrauterine insemination, it can help to explain that, potentially give a little bit more credence for moving on to something like ICSI. In people who have very high values, it might explain why one cycle of IVF or ICSI didn't work and why some couples will take 2 or 3 cycles of IVF ICSI in order to achieve pregnancy. It's not a particularly expensive test. It's similar to the cost of an advanced semen analysis. And if you're not frightened by the information that is available, I find it useful in select situations. But it's, if you talk to your own REI about it, they'd say, oh, I never run that test, or I do it on everybody, it's the best test, or it's useless. It's something that is very, very hotly contested amongst people who specialize in fertility. Finally, and this could have been the first slide, it could be the most important slide. Gynecologists are still specialists in female fertility. When we want, particularly an anatomic or surgical assessment of male fertility, we need to involve a urologist, and typically that urologist needs to have a background in the treatment and diagnosis of male fertility, which not all urologists do. There are some very common testicular pathologies such as a varicocele, and this is a varicocele here. It's a dilation of the normally occurring blood supply to the testicle, and as it becomes dilated, very similar to varicose veins in the legs, it generates a lot of ambient heat, often some inflammation as well. There can be an immune response that's generated, and that can have a tremendous impact on male fertility and sperm parameters. Decreasing the size of those blood vessels, either by surgery or embolization, often has an improvement in sperm function. And we'll just quickly talk about treatment options. I want to be able to spend some time on questions. Again, don't give up on intercourse. It can become very frustrating and stressful over time. The sooner you get on a decent vitamin, you will increase your chances for success. This is Fertile Pro. This is the one that we are currently carrying at Fertility Ontario, and we use it in concert with Vital Q, which is the source of coenzyme Q10. Taken together, these will greatly improve the chances for natural fertility. So before you become frustrated or think about moving on to traditional fertility therapy, I would really advise you to give Vital Q and Fertile Pro a try. The next step in sort of the hierarchy of treatment is IUI, or intrauterine insemination. As some of you may know, this is something I've been very critical of in the past because I do believe it's overused to a certain degree. But when it is selected properly, it can be quite effective. It essentially involves the transfer of washed sperm as high up into the uterus and as close to the fallopian tubes as you can get. And it's very effective in people who have a mild impairment in sperm count and motility, as long as the process isn't overused. So we do about 3 cycles of IUI at our center. Each cycle has about a 20% pregnancy rate, such that about 40% of patients will become pregnant within 3 cycles of IUI. Once you've gotten past those 3 cycles, the pregnancy rate drops very precipitously, and that's usually a point where we talk about moving on to something like IVF. Donor insemination is another great option for people who have very low sperm counts or who can't afford more advanced techniques. It is thankfully funded by the ministry in Ontario. If you want information about donor insemination, I would highly recommend going to creatingcanadianfamilies.ca, which is the homepage for Outreach Health Services. Finally, we're going to talk about the more sophisticated treatments, which are IVF and ICSI. In vitro fertilization, IVF, is not always thought of as a treatment for male fertility. It originated as a treatment for fallopian tube blockage, and so it's still commonly associated with female fertility. Male infertility is actually one of the main indications for IVF right now, and it's one of the reasons that we advocate so strongly that the government fund this procedure, is because there's a huge number of male fertility patients who could benefit from it. It has very high success rates in comparison to other treatments, and modern IVF has come a long way from the IVF of the 1980s and early 1990s, such that we see less side effects and lower multiple pregnancy rates. The cousin to IVF, which is not the same thing, is intracytoplasmic sperm injection. They are very, very similar, but the way in which the egg is fertilized is quite different in ICSI. It's actually a single sperm cell placed into a single egg. And in areas where the sperm counts are very low, such that even fertilization in IVF is improbable, ICSI is a very common modality. It is extremely safe. It does have risks with it, but there have been hundreds of thousands of ICSI cycles that have occurred globally. with thousands of children who have been born from that technology. So it is not considered experimental, and it is considered eminently safe. So that is probably, I know we got right to the hour there. I'm sorry that I was rushing. We always run a little bit over time, but I'd really like the opportunity just to crank out a few more questions.
We actually have a few here. Um, we have a question here from James. He's wondering, would you recommend a zinc supplement along with Fertile Pro and Vital Q and a multivitamin?
I, you know, the answer to people who ask questions about supplements and vitamins is, you have to be realistic about how much you can take in a day. The reason I like a supplement that has a lot of different elements in it is because it decreases what you need to take in a day. The Fertile Pro contains a very generous amount of zinc, so you're going to be getting that as part of that supplement. And then if you get the antioxidant effect of Vital Q, you're getting most of the things that you need. Um, Again, a well-balanced diet is always a fantastic start because that's how Mother Nature designed us to absorb these minerals and elements. So if you're not eating well, you're asking a lot of vitamins and supplements in terms of carrying the day.
That's great. We have another question here from Gord. He's wondering, how much should you save money wise for 3 cycles of treatment?
It depends on the treatment that is required. I think if you're looking to save money, you can, that's where tests like a DNA fragmentation index would come in, right? Like as an example, if money is tight and you're considering intrauterine insemination, if we have a $200 test that you can run that can tell you what your prospects are using IUI, then suddenly that greatly debated test has value to your particular situation. So it would generally be good to meet with a specialist and talk options. We're generally pretty open to talking to you about strategies to save money because we don't want to see people take a huge financial burden in order to build their family.
For sure. For sure. And it's definitely a question that, people certainly think of when going through the process.
Yeah, it's very practical.
Yep, absolutely. We have a question here from Megan. She's wondering if you see any differences in the success rates of IVF with ICSI between male and female factor fertility.
Yeah, actually we do. The thing with ICSI is that you're essentially forcing fertilization, right? Some of the guys that we are using sperm injection like ICSI in have very poor quality sperm. And again, sperm is half of the genetic material that makes up the embryo. So typically our ICSI population has a lower clinical pregnancy rate than our IVF population. They're close, but IVF usually beats out ICSI year after year. And I think that has to do with the fact that we are probably, forcing fertilization with a sperm cell that wouldn't otherwise be able to fertilize. And the problem with things like DNA fragmentation that, an embryologist would always come back to you arguing is that they cannot choose a genetically or chromosomally competent sperm for injection. So if you've identified that there's a high number of fragmented DNA sperm, and you haven't given the laboratory the ability to pick the good ones, then you're not really helping them, and it becomes subject to chance somewhat. So yeah, ICSI is often has lower pregnancy rates just because the sperm that gets selected for ICSI is often poorer. I don't know if that made any sense at all.
It did for me. If there's
Did it kinda? Yeah.
if there's any other questions, or that was a little unclear for people, just go ahead and we'll clarify. We have a really great question from Gord here. Gord's wondering, to meet with you, do you have to see your family doctor and then get a referral? And he also has some really nice words. He says that you've been very informative and you seem really friendly and have a great heart. So he thanks you.
Oh, I appreciate that. Um, We used to take appointments by referral only, and then eventually through word of mouth, we had a lot of people who were looking to self-refer. We actually really enjoy that interaction with those patients because they're motivated, they tend to have done a lot of research, and so now we have a self-referral portal on our website. You can go and fill out one of our online forms, and my office manager will get back to you within about a week or so. And our wait list is not horrible, you know. So yeah, we welcome self-referral. We don't like to cut your family doctor out of the loop, but oftentimes the wait to get in to see your family doctor is longer than the wait to get into Fertility Ontario. So realistically, the sooner you see a specialist, the better.
And for everybody, there's a chat box up on your GoToWebinar, and I've just typed in the fertilityontario.com link. Let me see if I can get the exact one. The self-referral here. There it is. I'll give you guys the exact link if anyone's thinking about doing this. There you go. Awesome. I don't see any more questions. If there are, feel free to type them out now. This is really an opportunity to have all these questions answered. I know we're running a little bit over time here, but anything we can't answer tonight, John's really awesome with getting back to everybody and in emails and questions and things like that. Oh, great. We've got some popping in. Um, Steve is wondering, do you have a webinar on female infertility?
Yeah, we do. We've had a webinar on polycystic ovarian syndrome, on natural fertility supplements, both of which are available on our YouTube channel for Fertility Ontario. We initially had a webinar on aging and female fertility, which looked at the effects of age on conception and fertility. Unfortunately, that one didn't get recorded, so it's going to get replayed down the line. Next month, we haven't determined what our topic is for our webinar, but we always sort of look to our patients to provide some topics for us. And in 2013, we're hoping to get some additional speakers on board, just so that we can get some of the the subspecialty areas like endometriosis covered. So yeah, we will be continuing to have these on a monthly basis. They are available online through YouTube. They take a long time to get to YouTube, just because you can imagine that an hour and 15 minutes of video takes a long time to render. So you have to be patient with the people at TBK Creative. That was a hint, yeah.
Yes, it was.
But yeah, and if now that you're registered in our system, you'll be getting email alerts about all of our upcoming webinars.
Awesome. Awesome. And in another spot too, I know I mentioned this at the beginning, but there were kind of still people trickling in at about 8 and 8:10. Um, we have a really great Facebook community online. Actually, it's I think I've got the link there in the chat box. And when our webinars come up, and when our there's a number of things that actually come up. Right now, Fertility Ontario, we didn't really even talk too much about it, but there's a program running called Laura's Wish, and there's a really great story behind that. So, for Fertility Ontario is actually going to be granting one individual or family a free cycle of fertility treatment through this program, through this amazing woman. You can read about it on the website. So really kind of all the update information, all these webinars, they get posted up on Facebook. So go ahead and like us, and hopefully when we're doing some kind of neat things, you'll get little notifications in your feed if you're a strong Facebook user.
That's great. And so I think we're going to wrap up. Unless there are any other questions at all.
No, I don't see any. So
Okay.
that's it actually.
Yeah, and so don't hesitate to email me if you have any questions. For those of you who are watching this on our YouTube channel, feel free to send us an email question at info@fertilityontario.com. The people who registered and attended tonight were given my personal email address, and please don't hesitate to use that. Finally, I just, thank you so much for coming out, because through your questions, you helped me be a better doctor for people. I also really appreciate that you took up, 90 minutes of your time to come out tonight. And I hope everyone got something positive from this tonight.
Awesome. Thank you everybody for joining us. And there is being $5. There's $5 donated for every person who's joined us tonight, which is really fantastic. So you've helped there as well. Um, have a really great evening, everyone, and we'll notify you when the next webinar comes out.
Okay, great. Thanks so much, Melissa.
Yep. Bye, everybody.
Good night, everybody.